Sufficient preparation for any examination is vital. It is important to introduce yourself clearly to the patient, making sure they are comfortable and that exposure is adequate. Initial inspection should be made from the foot of the bed. Note should be made of any swelling, deformity, muscle wasting or scars. Leg length can be simply assessed by comparing medial malleoli. Palpation of the knee can at first appear quite daunting. There are many different anatomical elements, all listed here, that need assessing. That is why it is important to develop a logical approach to palpation of the knee. The knee can most easily be palpated with the leg flexed to 90 degrees. Starting at the tibial tubercle, work up and around the patellar tendon logically to determine any tenderness. Work logically along the lateral tibial plateau and also the medial tibial plateau, around the medial articulate edge of the femur and the lateral articulate edge of the femur, along the line of the medial collateral ligament and also the lateral collateral ligament and down onto the head of the fibula. Not easily seen here is palpation of the biceps tendon at its insertion onto the fibula head. Finally, at the back of the knee capsule, it is possible to palpate the hamstring tendons, the medial and lateral head of gastrocnemius, and the popliteal fossa. Again, from a lateral view, start at the tibial tubercle and work logically all around the patellar tendon. Feel along the tibial plateau, the fibula head, and the lateral collateral ligament. The insertion of the biceps tendon can also be felt at the back of the knee capsule. Pathology of the popliteal fossa and posterior knee capsule may best be felt as the knee is slowly extended. A knee effusion can be elicited by first clearing the medial gutter and then encouraging any cross fluctuation by applying pressure to the lateral gutter. Any effusion would be seen as it flows back into the medial gutter. Again, this is more easily seen on a medial view. There is no effusion present in this healthy knee. The patellofemoral compartment is a common area of pathology. Tenderness in this area can be elicited by forcing the posterior surface of the patella down onto the femur. The posterior medial and posterior lateral surface of the patella can be palpated with gentle displacement of the patella. The patella apprehension test involves gently displacing the patella whilst flexing the knee, looking for resistance or patient apprehension. Movement. In the knee, this involves both active and passive flexion and extension, stability tests for the medial and lateral collateral ligaments, and stability tests for the anterior and posterior cruciate ligaments. Ask the patient to bend their knee as much as possible. Full flexion is obtained when the calf touches the back of the leg. Passive movement can then easily be tested at the limit of active flexion. With the leg out straight, the patient is asked to push the knee down onto the examiner's hand. Pressure felt on the hand accompanied by a rise of the heel indicates full knee extension. Stability of the lateral and medial collateral ligaments is best assessed with the knee in about 10 degrees of flexion. The foot is supported to prevent rotation at the hip. A valgus and then varus strain is applied whilst checking to see if any pain is created. Testing of the medial and collateral ligaments can be done in a number of ways, depending on the relative size of the examiner's hands and the patient's leg. It is important to practice each method and find one with which you are most comfortable. The testing of the medial and lateral collateral ligaments can be more easily appreciated from a different view. Flexing the knee to about 10 degrees, a valgus and then varus force can be applied in a number of different ways, as mentioned earlier. Testing of the anterior and posterior cruciate ligaments can be tested with the knee flexed to about 90 degrees and the foot restrained from slipping or being pulled down the bed. It is important to look from the side to ensure the tibia has not sagged backwards, and then apply a firm but steady pull forwards for the ACL and a push backwards to test the PCL. Again, for clarity, here we show a lateral view. First, check the tibia has not sagged backwards, and then apply a firm but steady push to test the PCL and a firm but steady pull to test the ACL. Alternatively, Lachman's test can be used. The examiner's knee is used to support the patient's knee, one hand fixing the patient's femur by pushing it down onto the examiner's leg, and the lower leg is then pulled forward with the other hand. We will now demonstrate two further clinical tests, the Apley-Grind test and the McMurray test. Apley's grind test can be used to elicit tenderness in the tibiofemoral compartments, including the menisci of the knee. One hand is placed above the femur, the other below the heel. A compressive force is applied at the same time as the tibial articulate surface is grinded against the femur. By shifting the examiner's hands, the tibia can be distracted from the femur and the rotation repeated, preferentially stressing the ligaments as opposed to the joint surfaces. Once again, for clarity, here we can see it from a medial view. Compressive force is applied at the same time as the tibial articulate surface is grinded against the femur. Shifting the hands allows the tibia to be distracted from the femur, preferentially stressing the ligaments as opposed to the joint surface. For McMurray's test, the knee needs to be flexed fully. The finger and thumb of one hand are placed on the joint line. Rotate the tibia whilst feeling with the finger and thumb for a click or clunk as a torn piece of meniscus gets trapped and then released between the femur and the tibia. Then, preferentially stressing the medial compartment, keep the knee in external rotation and varus and bring it out into full extension. Here, for clarity, we will show the maneuver again. If the knee is painful whilst manipulating the tibia, but no click or clunk felt, then it remains a negative McMurray test. A positive test is only when there is a palpable clunk or click during this maneuver. In summary, it is important to remember that adequate preparation is vital for any examination. Look, feel, move are the cornerstones of all orthopedic examinations. And finally, it is important to practice and develop your own system that you are comfortable with.